Anna sir, good evening, sir. Good evening, friends. I'm sorry for a couple of minute delay today. We have eminent speakers, invited speakers, Professor Jacob Paul from CMC Vellore, Head of Surgical Endocrinology. And we have Dr. Marudu Pandian and Dr. Sheikmar will be joining us shortly. We warmly welcome our senior faculty here, Professor Kanna sir, Professor Shenai sir, and other senior faculty who have been joining us regularly. And I warmly welcome Professor Jyoti ma'am, who has kindly contributed the postgraduate from Gadag Institute of Medical Sciences. Warm welcome to you also, ma'am. And I could see other senior faculty whom I do not know. Sorry if I not able to call you by name, but warmly welcome you for this evening's program. Friends, we have two important cases for discussion today. One is the case of a carcinoma thyroid to be presented by Dr. Shoaib. Shoaib Baig is from Gadag Institute of Medical Sciences, Gadag. And we have Dr. Ashish Vagasia from Dr. Dhyanesh Balekar's unit from Terna Medical College, Mumbai. We have Dr. Marudu Pandian sir also joined. Sir, good evening, sir. Thank you for joining, sir. So, good evening, sir. And we will have the thyroid case first. Dr. Shoaib, please share your PPT, introduce yourself, your unit chief, your head of the department, and start your presentation. Make it full screen, ma.
Sir, is it visible, sir?
Perfectly visible. Good luck to you.
Thank you very much. Good evening to all the eminent faculties. My name is Dr. Shoaib Baig. I'm a second-year resident in the Department of General Surgery, JIMS Gadag. Today, I'm going to be presenting a case of midline neck swelling. The mentor for the same was Dr. Syed Zamir sir, who is assistant professor in the Department of General Surgery. And the guide for the same is Dr. Jyoti S. Karegaudar ma'am, professor and head, Department of General Surgery, JIMS Gadag. My patient is Mrs. X, who is a 60-year-old female patient who is a resident of Gadag, Karnataka, a homemaker by occupation, presented with the chief complaint of swelling in front of the neck since last 25 years and recent increase in the size of the swelling for the last 1 month. The patient was apparently normal 25 years back. 25 years back, her husband noticed a swelling in front of the neck, mainly on the right side, which was initially of size 3 × 3 centimeters, insidious in onset and progressive, with a history of recent increase in size for the last 1 month to the current size of 8 × 6 centimeters, extending to the midline. There is no history of pain in the swelling. There is history of loss of appetite and weight, about 5 to 6 kgs in the last 3 months. There is no history of difficulty in swallowing, no history of recent change in voice, no history suggestive of hypo or hyperthyroidism. There is no history of any other swellings in the neck, no history of dyspnea, no history of bony pain, hemoptysis, or jaundice. Past history, there is no history of radiation exposure in the childhood. She is not a known case of diabetes mellitus, hypertension, or tuberculosis. There is no history of intake of any long-term medications. The patient, personal history, the patient consumes mixed diet. She has sound sleep, good appetite, and regular normal bowel and bladder habits. She attained menopause 13 years back. The cycles were regular of every 30 days of normal flow. Coming to the case summary, this is a 60-year-old female patient with the swelling in front of the neck, mainly on the right side, since last 25 years, with a recent increase in size since 1 month, with no pressure symptoms or neck nodes. There is no similar symptoms of hypo or hyperthyroidism. This is my provisional diagnosis based on history would be this is probably a thyroid swelling, which is in euthyroid state. Sir, may I continue, sir?
Please wait, ma. Please wait. Faculty, please take over. Paul sir, Marudu sir, Rajgopal sir. I wish you could go to the first slide.
Can you go back to your history?
Yes.
So she has noticed, you said, for swelling for 25 years, during which period there was no growth at all, is it?
There was growth, sir, but it was very slow, and it was initially of size almost of 2 cross 2 centimeters. But since last 25 years, it had progressed to just 3 cross 2 centimeters. But there was progressive increase in recent increase since last 1 month.
Okay, so that what does that tell you? So that is basically you're saying that 25 years he's had, but there's no noticeable increase. That's a good word to use. But recently, for the last 1 month, she has noticed a increase in growth. So it will be good to say, has she felt that it has doubled in size? Because by your description of the size, it has more than doubled in the last 1 month. So what do you think of when you have, and this is in the midline of the neck, no? So in front of the neck.
Yes.
The history. Okay. So it's likely that gives you a very strong clue what the
Sir,
implication on pathology.
sir, one of the things that it could have been a benign swelling which has undergone hemorrhage into the swelling, which has a recent increase in size, one thing. And secondly, it could have been a long-term benign disease which has recently converted into a malignant. It has gone into a malignant change.
Yes. The second point is in the history, you said there's a loss of appetite and weight 5 to 6 kilos in 3 months. So do you think that could be related to this?
Sir, usually thyroid swellings do not present with history of weight loss, sir. But since the patient had a positive history, so I just commented on.
Yeah. So what should you do in this situation? So given the fact that thyroid normally, except in case, of course, if there's toxicity, in which case there will be increased appetite and weight, and you will have other symptoms of toxicity. So here it doesn't seem to be related to thyroid toxicity. So if you have loss of appetite and weight that's significant, maybe in 3 months, then what should you also ask for? That's an important. So if there's a long case, we want to see how you're thinking. So you said very correctly that it's unlikely to be related to thyroid. And we are not treating this patient only as a neck lump, isn't it? You want to treat her entire presentation. So therefore, what else should you do in this situation where there's a significant weight loss?
Sir, I would like to look if
in
there
the
are any.
Yeah, go ahead.
Any GI symptoms?
Very good. So you need to also investigate what could be the other reasons for weight loss. For simple, what GI symptoms are going to ask for?
History of diarrhea, history of decreased appetite with history of vomiting.
Okay, so you want to know whether it is only the loss of appetite that's caused the loss of weight? Is that proportionate? So you have to investigate the diet a little bit, or is there some alteration in the bowel habit, as you said? Either there's diarrhea or there's altered stool, or is there blood in stool that may be hiding a malignancy? These are has there been nausea or vomiting along with the loss of appetite? All those symptoms actually have to be mentioned because you have told that there is a significant loss of weight, isn't it?
Yes.
So that's what we're looking for, whether you're going for a complete evaluation of the patient. Okay, good. I just wanted to make that point. Apart from maybe hiding a malignancy, these are has there been nausea? Sorry, I think there's some sound that's coming back. But the other thing is about the family history. I don't remember you. Since you have said that it's a significant growth and malignancy is one of your concerns, what family history would you ask for?
Sir, I would like to ask for history of any similar swellings in front of the neck in other family members, or if there was any history of any other malignancies that were diagnosed in the family.
Okay. What conditions with goiter run in the family that you are aware of?
So one is if that might have all the family members, because of the iodine deficiency, the other members also may present with swellings in front of the neck. Secondly, if there are familial carcinomas which are there in thyroid, like medullary carcinomas or familial variants, then the patient's other members of the family might have previous history of malignancies.
Okay, so familial history of carcinoma, autoimmune thyroid disease can run in families, and just familial goiters. What are they called?
But
Dyshomogenetic goiters.
this
Also,
also,
she may be coming. Is she from an endemic area? She's from Gadag. What do you know? What
yes,
iodine in diet specifically? I don't remember you mentioning.
sir,
Is she
currently
consuming
there are
iodized
no
salt?
the recent data that I checked regarding Gadag being an endemic place is not very. There are no current statistics which say that this is an endemic place, sir. But people here usually tend to consume iodized salt everywhere. So
Okay. So you must ask specifically also in this history because you have a long-standing goiter. So the family history of goiters, the consumption of iodized salt, and what are the other causes of goiter formation?
sir, it could be because of uh, consumption of goitrogens such as cabbage or kale or rape, or it could be because of certain long-term medications also. If a patient is a known case of psychiatric disease, patients taking lithium, or if cardiac patients who are taking amiodarone uh, or other iodine-containing drugs, the patient may present with goiter.
Okay. Thank you. And one more thing is, since she's had it for so long, we need to know specifically, has she had any evaluation for this in the past or any attempt at treatment in the past?
No, sir, she hasn't shown it in the past because there was no any associated pain or discomfort that she experienced. The recent increase in size was the one which she felt that there is something wrong, and she has come recently. There was no previous treatment history, nor there was any history of any medication that was taken for the same thing.
Okay. And this history of menopause, you said, was 13 years ago. So I assume that's
Yes,
around 40, well, she's 60 now. So is
yes,
that the normal age? Do you know the normal age of menopause?
usually between 45 to 50 years.
50. Okay. No, that's good. Between 45 to 50 in India is correct. Okay, well done. So I hope you've picked some points. Any other examiners would like to ask? Please go ahead.
This is Dr. Marthu Pandian. What
Yes.
type of malignancy you will expect in a long-standing goiter when it turns into malignancy?
Sir, usually we tend to expect follicular neoplasms in a long-standing goiter, which usually goes into nodullarity, and then there are chances that it can go into follicular carcinoma thyroid.
Yes. Good.
So what is the difference between a rapid increase of the thyroid and sudden increase of the thyroid?
Sir, I'm not sure of the time duration regarding the same.
So sudden is all of sudden.
Yes.
Okay. So within few hours or within few days, it is occurring. In which condition you will get the sudden increase?
Sir, if there is a hemorrhage into the cyst, there can be a sudden increase in size.
The rapid increase is for the malignancy. You know?
Malignancy.
That it is coming in 1 month, 2 months, 3 months. Like in your patient, this
Yes.
was there for so many years, and for last 1 month, it has started increasing in size. Okay.
Yes.
Why did you ask the history of hemoptysis in this patient and the jaundice?
Sir, she's an elderly patient of 60 years of age with a history of recent loss of appetite and weight. So, with the history of swelling in front of the neck, so that was a probable thyroid swelling which might have metastasized. And the usual places where it gets metastasized is bone, lung, and it's usually the bone and lung, and sometimes it's the liver also.
Is the lung a very common site for the metastasis from the thyroid?
Sir, lung, it's usually common in follicular carcinoma of thyroid, sir, but in papillary, it's usually the bone and the nodes which are usually involved.
Papillary goes to the lymph nodes.
Yes, sir.
And
Lymph
follicular
nodes and
goes
the
to the
bones.
bones, flat
Bones.
bones.
Yes.
That is a common sign. It can occur anywhere. It can go to the lung and But they are not very common site for that. Huh?
Yes.
Okay. Where does the medullary carcinoma goes? What is the site of
Sir,
the medullary carcinoma?
Sir, the most common metastasis is to the lymph nodes itself, but it can also go to the lung, liver, and bone.
Okay.
Lung and liver is more common.
And
But
anaplastic
more
carcinoma?
commonly, it goes to the lymph nodes. Sir, anaplastic carcinoma is more of a local disease which is very rapidly progressing and infiltrating with thyroidal extension along with the involvement of the lymph nodes and deeper structures. But usually, patients present late with severe
No, the
respiratory distress.
patient succumbs to the local problems.
Local problems.
Before it goes to the systemic, the patient
Systemic,
succumbs to the local problem in the case of the anaplastic carcinoma.
Yes.
Okay.
Go ahead with the clinical examination.
One more small point I'd just like to ask is the symptoms of compression. I think you said there's no difficulty in swallowing and there's no change in voice.
Yes.
When the tumor presses on the trachea, what
Yes.
symptom do you usually get? The patient.
So we usually tend to get striders whenever there is compression of trachea.
No, that is very late malignant. That's extreme. I'm talking about just large swelling pressing against the trachea. The patient will usually complain of either a foreign body sensation in the throat or a choking sensation that may vary on position. Sometimes when lying down one side, the other side. Choking and foreign body sensation. These are the local compressive symptoms.
That is
Okay.
orthopnea. Usually they'll have a orthopnea, the huge thyroid, what sir is saying, no, is show
Yes.
in
Yes,
lying down position, they feel difficulty in breathing. And one
Yes,
more, Dr. Khanna sir was asking anaplastic, they present with the respiratory difficulties, especially obstruction. Dyspnea
Yes,
can see it as. Okay.
Okay, please move to the examination.
These are the images of the patient before going to the exam. Coming to physical examination, the patient was examined after taking consent and adequate exposure and in a properly lit room. The patient is conscious, cooperative, oriented to time, place, and person. She is moderately built and nourished. Pallor is present. There is no icterus, cyanosis, clubbing, lymphadenopathy, or pedilledema. Pulse rate is 82 beats per minute measured over the right radial artery in sitting position, regular rhythm, normal volume and character. Blood pressure is 130 by 80 millimeters of mercury measured over the right upper arm in sitting position. Respiratory rate is 18 cycles per minute. The BMI is afebrile, and there are no signs that are seen in general physical examination. Local examination of the patient, then inspection, a solitary swelling of size 8 cross 6 centimeters situated in front of the neck, ovoid in shape, extending laterally up to the lateral border of the sternocleidomastoid on the right side and anterior border of the sternocleidomastoid on the left side, above up to the thyroid cartilage and below up to the swelling appears smooth. It moves with deglutition. Lower border is seen. There are no other swellings seen on the neck, over the neck. There are no dilated veins seen over the swelling or chest wall. Trachea appears to be central. There are no eye signs present, and the patient has normal neck movements. Palpation. There is no local rise of temperature. The swelling is non-tender. It's of size 8 cross 5 centimeters involving the right lobe and the isthmus. There is one nodule of size 2 cross 2 centimeters felt at the lower border, which is hard in consistency. Rest of the inspectory findings are confirmed. The swelling has well-defined borders. It is hard in consistency and deep to deep cervical fascia. The carotid pulsations are felt and are shifted laterally on the right side. There is no thrill felt. There are no palpable cervical lymph nodes. Trachea appears to be shifted on left side on palpation. Percussion of the sternum is resonant, and there is no bruit heard on auscultation. And the trachea appears to be shifted towards the left side on auscultation. The systemic examination, cardiovascular system is normal. The rest of the systemic examination appears to be normal. Spine and cranium, the skull examination is normal. Diagnosis. This is a 60-year-old female patient with a malignant thyroid swelling in euthyroid state with no pressure symptoms or no evidence of metastasis.
Okay, just to come to the initial part of your examination, it's common practice or the local examination and inspection, you will always talk about the skin first. No, the surface you said appears smooth. The skin over the swelling, there's no scars
No
of
scars, no,
biopsy or previous surgery, or
no,
no sinuses, no dilated veins. Yeah,
Yes.
so those are that first part of the examination. The rest of
Yes.
inspection is okay. Actually, when you do inspection, we also look at the laryngeal, the thyroid and cricoid cartilage, whether that has been shifted. Because the trachea is actually difficult to visualize. Trachea is what you
Yes.
see on palpation. The
Yes.
one major point I want to make is, I think you said most of the findings well, is the mobility.
Yes.
When you have especially a suspected malignant hard swelling like this,
Yes.
you actually can hold the swelling and move it. How do you check for mobility? What is of thyroid swelling?
Sir, we stand in front of the patient with patient in a sitting position with a slight flexion of the neck, and we move the swelling in horizontal direction or vertical direction.
So you move, you hold, you grab the whole swelling and move it in which direction?
Sir, usually we move it in the horizontal direction and check, because movement with in vertical direction is usually visible in the movement with deglutition part if the swelling is visible.
Okay, no, that is it's a little more than that. See, the normal movement with deglutition that occurs, that you have to know what is the reason for movement with deglutition.
So
The favorite question.
Reason for movement with deglutition is because the thyroid gland per se is attached to the cricoid cartilage through the Berry's ligament, and the cricoid and the laryngeal complex is in contact with the pharyngeal muscles, the inferior constrictor, which is attached to the oblique line of the thyroid cartilage, which on contraction during swallowing is going to move the whole laryngeal complex above, which and the thyroid. Because it is attached, it has the pretracheal fascia, which is attached to the thyroid complex. It moves along with the laryngeal complex.
Yeah, so the thyroid is enclosed by the pretracheal fascia, which forms the false capsule, and is posteriorly, as you said, attached. The isthmus and lobes are attached to the surface of the trachea, then the Berry's ligament to the cricoid thyroid junction, and then, as you said, the oblique line. Yeah. So, and why does it move up with deglutition?
Sir, movement with deglutition.
Yeah. Why? So you said the trachea moves up and pulls the thyroid.
Yes.
So why is the trachea moving up with deglutition?
Sir, the constrictor muscles are attached to the base of the skull through the pharyngeal raphe. And once the inferior constrictor is going to contract during the swallowing process, it's going to move up, and that the in the same point, the laryngeal complex also moves up along with the thyroid gland.
Okay, in order to close the airway during the act of swallowing and prevent aspiration. Okay, so that's your complete answer. What is the purpose of that movement? Is prevent aspiration. So that way, it's very useful for us that this whole thing happens, because it's easy to diagnose a thyroid swelling in the midline, which will move up.
Yes.
Okay, so what is the differential diagnosis of structures that move up with deglutition? Now, most often it is thyroid. What else can it be?
So it can be a prelaryngeal or a pretracheal lymph node which is enlarged. It can be a subhyoid bursa also which moves, and it can be a laryngostele if it is over the lateral aspect of the.
Very good. So lymph nodes. There are two more things. What other structures are there? Parathyroid tumors can also present there, and any primary tracheal or laryngotracheal tumors. All of them will be arising from the laryngotracheal apparatus, which move up. Okay, all these, yes, you mentioned. Now, I'm back to the reason why I'm asking about mobility. When you hold the thyroid lump, you want to see whether, if it is malignant, is it infiltrating the tracheal fascia? So normally, when you hold the trachea, can you move your trachea up and down? You cannot, no, because it's only swallowing that can pull it up. It cannot be done externally. So when you move the thyroid over the trachea in a vertical direction, it will not move, no. If it is infiltrated into the tracheal fascia, which is a sign of malignancy. Whereas a normal thyroid, which is enclosed in pretracheal fascia, has some intrinsic mobility, and you can actually move nodules vertically over the tracheal surface. So loss of vertical mobility is an early sign of infiltration into the tracheal fascia. It's a very important sign, actually, clinically. Now, the horizontal movement is different. Normally, even if it is infiltrating tracheal fascia and there is loss of vertical mobility, you will have preservation of horizontal mobility, because the laryngotracheal apparatus will move along with the fixed nodule. Yeah. If that's because you can hold your own laryngotrachea and move it horizontally, the same thing will happen. So fixity to trachea does not prevent horizontal mobility. So what is the sign, or what is the cause of fixity in a horizontal direction? That means the tumor has become so advanced that it has grown posteriorly. What is behind the trachea? What fascia?
Is prevertebral fascia.
Prevertebral, very good. So it's a sign of prevertebral fascial infiltration, which will cause fixity in a horizontal direction also. So these are two very important clinical signs. Okay. And when you have a hard mass like this, which is probably pushing, you said the carotid pulsation is shifted on the right, but what else should you say if it's a hard mass? And supposing there is loss of mobility, you must check whether what is Berry's sign? What is Berry's
Berry's
sign?
sign is not able to palpate the carotid pulsations at its normal position.
Okay, Berry's sign
It is usually because of the infiltration of the
loss of carotid pulsation in the presence of an ipsilateral hard fixed mass. So it's a sign again of advanced malignancy. So all these three things: loss of vertical mobility early, Berry's sign, and then fixity horizontal. These are signs of advanced malignancy. Okay, and used to be taken as indicators of inoperability in the early days. Now, of course, we go by the CT and more detailed evaluation. But these three signs are important. Okay.
So can you tell that in the upper neck, if there is swelling is there, which does not move vertically, but it can be moved horizontally? What is the differential diagnosis of that? It cannot be moved vertically, but it can be moved transversely.
There are thyroglossal cysts.
No, not the thyroglossus. Thyroglossus can, it can move with the deglutition, it will move, can move its side also. Somewhere in the carotid triangle. Let me be more specific about that.
Sir, it can move horizontally and not vertically.
Yes, that's right. Yeah.
Sir, if it is a carotid body tumor.
Yes, carotid body tumor. That is one. Any other tumor which will be almost in the same area, which will also have the same thing. You know what is there in the carotid sheath?
Sir, there is internal jugular vein, the vagus nerve, and the carotid artery.
Yeah,
it can be aneurysm.
Can you get any? No, can you get anything from the vagus nerve?
There are chemo that I'm not sure.
What is glomus jugulare? Glomus vagal. Have you heard about that?
Sir, I've heard, but not exactly able to.
Again, in the carotid sheath, there is a glomus tumor is there in that area. That will also have the similar finding that it will not move vertically, but it will move transversely.
Yes.
Okay.
Yes.
Yeah.
Shoaib,
Yes.
can you
Yes.
hear me? Yeah,
Yes,
just
sir.
this slide, whatever we are seeing,
Yes.
you see what you have written in the first line and what you have written in the second line. So would you like to correct this line in the university examination? So indirectly, let us not waste the time. So first finish everything related to the swelling. Is it okay?
Yes. Yes.
So typical size, shape, surface, all that, whatever, dilated veins. You have written there. Dilated veins over the chest wall you have written, right?
Yes. Yes.
So what is the significance of this?
Sir, it is on inspection. I would want to look if there was any retrosternal extension of the thyroid gland.
Any chances in your patient? Chances.
Sir, if there was lower border visible, then there was no chance.
Any other explanation people give, even though it's rarely found? Suppose even if you see the lower border in your patient where you suspect malignancy.
Sir, if it is a primary, if it is a malignancy arising from the thyroid rests in the mediastinum, or if there are.
So mediastinal nodes, chances are very, very less in your patient, number one. So what I wanted is the skin, sign, shape, surface, dilated veins will go up. Okay, swelling.
Yes, sir.
Okay.
Yes.
After that, you should mention also pulsations. Okay.
Yes.
Pulsations.
Yes.
You'd like to know the pulsations over the swelling. Okay.
Yes.
Once loco-regional, that's how it is. Loco-regional.
Yes.
So one is local. Then, of course, you like definitely about the swellings, trachea.
Yes.
It's a good practice to put the eye signs naturally later in the sense. See,
yes.
It is not like looking at the thyroid once and looking at the eyes up.
Yes.
Looking at the thyroid, palpating thyroid, palpation of Knapp-Jigger's method or whatever. It's basically, we'd like to do a little more details. May not be in your patient, but just to keep it in mind, thyroid and eye signs have to be given due importance. Okay.
Yes.
Your case is a different situation, but still make a practice. Now, what is this last treatment? Normal neck movements. What is that?
Sir, if there is any restriction of neck movements in the patient, it can, because she is an old lady, there can be cervical spondylosis, which is.
What does it matter in the sense of, so all old people will take it for granted they will have cervical spondylitis, or in what way? What way? I agree, it's a good practice to look, but what is that you have in mind?
Sir, it's more of for the operative procedure that is there, because we want good neck extension. We want good neck extension during the
not a very common practice to mention like that. Patients who are 60 plus, you know, there are so many things you have to look after. Not,
yes.
I know you are putting the patient. So I just want to ask one other question, that what are the positions on inspection you would like to do in your patient of thyroid swelling?
Sir, usually if the patient is having, usually we do it in mild flexion, sir, the inspection part, standing in front of the patient. But if the patient is having a very short neck, or if the patient is very obese, then we usually tend to use the Pizillo's method, which is going to be extension with the arms at the back of the so that we have a proper.
My question is, how do you make the inspection of the thyroid looking more prominent without Pizillo's? I'm not sure. I saw the picture very rapidly was changing. Just a simple, just show the picture once, no problem about that. Yeah. See what you have done in the second picture. No, just go back. Go back. Second picture.
Sir, see, there are.
See that chin. What you have done the chin? Chin up.
Sir, she's clenching the.
No. That's okay. Clenching, chin up. So
yes.
that means you extended the neck, correct?
Yes, it will cause the deep fissure to be more tense, and there will be less.
No. It's actually cervical lordosis happens little bit when you extend, like a opposite tonus of tetanus and all. See, look at that. How exactly you see the difference between the first picture and the Second picture. Okay. So
Yes, sir.
you are not able to see the thyroid properly, just simple extend the neck. Number
Extend.
one.
Yes.
And secondly, you see the sternomastoid on the right side.
Yes.
No, what did you mention that on inspection? That's actually
No, like prominence of the sternocleidomastoid.
Prominence is
No.
there. And also,
Yes.
if I'm not wrong, it is pushed also to the right side. That means obviously it is growing a large size deeper to it and pushing it on the right side. And left is hardly visible. And tracheal shift is there. I'm seeing from here. According to me, there's a tracheal shift. So left side doesn't look like having any enlargement. Yes, I am only inspecting whatever from here. These are few things from my side. Yeah, please.
Shoaib, can you tell us what are the normal neck movements?
Sir, flexion, extension, and rotatory movement.
What degree of flexion is normal?
So when you read this flexion and all, Professor Jailal, like, serious. Yes.
What is the extension? You say it is a normal.
Yes. Sir, I'm not sure of the degrees.
Then why do you want to unnecessarily put in the examination? So you can't make 70% extension is normal. You can't get a full extension like that. Normally, what you say. And lateral rotation is a wide range. Even if it is a 20 to 70%, it is called as a normal. So there is a wide range of movement is normal. So neck is not necessary when you are examining thyroid unless it is obvious. When you say like Lados, what is obvious, then you have to say. Otherwise, don't waste your time. You have only 40 minutes. You are going to examine the neck examination. It will not enough for you.
Yes.
I just want to make one quick point here in the picture. Can you see on the right side that there are two veins actually which are prominent? What do you think those are? Superior to the swelling.
Yes.
There are two lines. What is that?
Sir, anterior jugular vein.
Yes, very good. Those are the anterior jugulars.
Anterior jugular vein. Yes.
So they are dilated actually. Normally you don't see the anterior jugular so prominent. So I think sometimes, just by rote we say no dilated veins, but we always say what you see. So when you look carefully, immediately, as Dr. Shenoy pointed out, the right sternocleidomastoid is also pushed out. And there are two prominent veins, which are the anterior jugulars dilated because this swelling has squashed them against the investing fascia. And they have therefore got the venous return is restricted and the superior component is dilated. That happens often in large thyroid. So you must point that out here.
Paul, sir, I have one small thing to say.
Yes.
The patient is clenching their teeth. See, correct, no? Shoaib?
Yes, sir.
See, I don't know whether it's elderly lady skin that,
Yeah, it's
yes,
just
sir,
that she has
it
opened
appears
her
to
mouth.
be more like a skin, sir. Because
see,
on a normal flexion, there were no visible veins on the anterior aspect of the neck, no any veins visible. It is just because of the extension that folds of skin were visible during exam.
we have the disadvantage of that, you are the person who has seen the patient, but we can only guess, probabilities. Okay, right, please.
Okay, go ahead. Professor Mardu, you have to ask some question.
You go forward. You are going.
Sir, I think sir is gone
Sir
for
is
some
not
call,
there.
sir. He's not
Okay,
with us, sir.
Okay, come to your final diagnosis. I think that's where we were. Are there any other questions on the examination?
Yeah, I just want.
Where did you auscultate the thyroid?
Sir,
where did you auscultate the thyroid?
So I auscultated at the superior pole, one thing for thyroid and for the sounds for the trachea.
Why did you auscultate at the upper pole?
Sir, usually we tend to hear a bruit in case of if the patient is hyperthyroid, or because the superior thyroid artery is more superficial and it has a bruit.
And why not at the lower pole?
Sir, lower pole usually the inferior thyroid artery is more deeper and it tends to give off branches because of which we are not able to hear in growing.
Do you have an inferior thyroid artery at the lower pole?
It usually branches also, and it comes from the more from the lateral side than from the inferior pole. It doesn't come at the inferior pole; it comes posteriorly, and it comes more towards the lateral side, and it enters. It gives off the branch.
Yes. Yeah, that is the reason, and that is deeper also. No?
Yes.
What is there on the inferior pole of the thyroid? What vessels are there on the inferior pole of the thyroid?
Sir, usually the branches of the inferior thyroid artery, or sometimes there can be a thyroid artery also.
Usually
And
on
there
the
are going to be
inferior pole of
veins.
thyroid,
Veins.
yeah, thyroid veins are there. No?
There can be veins, multiple
the
veins
inferior
which are
pole,
going inferior thyroid veins which are.
Yeah. So there may be one vein, or maybe many times there are more than one veins are there at the inferior pole.
Yes.
So if you look at the superior thyroid artery, it is accompanied by the superior thyroid vein.
Yes.
Middle thyroid vein does not have a middle thyroid artery, and the inferior thyroid, both they run separately. Vein and the artery, they run separately. Right?
Yes, sir. Yes.
Okay. Yeah. You can go with the diagnosis now.
So, Shoaib, I might have missed, sorry to say, you have to specifically look and mention any lymph nodes you have mentioned, swelling in, you can't say in a PG, so any flat bone swellings. I hope you have mentioned that specifically.
Specifically, I have mentioned it, spine and cranium is within normal limits.
Okay, I mean, see, that's the problem here, spine and cranium. Some people come with the sternoclavicular joint swelling. Some people come with even intercostal ribs, sternum. So like that, specifically you have to mention, I look for, okay?
Yes.
And especially thyroid. See, we are expecting a postgraduate exam. So other cases, CUJ skeletal system normal. You are suspecting definitely a malignancy here. So that's what your diagnosis also. So pulsatile bony swellings. Like
pulsatile bony swelling.
Whatever it is. So specifically look for more than tenderness. Thyroids produce pulsatile swellings.
Pulsatile bony swelling.
Breast produces more tenderness. So that's the difference. The two vertebrae. Yeah, that's all some of the small things. Yeah. Okay.
Where do you get pulsatile swelling, Shoaib? It's an osteolytic lesion or osteoclastic lesion?
Sir, it is osteoclastic lesion.
Thyroid, follicular carcinoma.
What? Yes, sir. Follicular carcinoma and renal cell carcinoma usually tends to present.
Present what?
Pulsatile bony swelling.
No. That's what do you mean by
they are
that?
Usually on chest radiograph, they are usually osteolytic.
Osteolytic. Then what is that swelling? What is that pulsation? Normally you see in the skull. And what is that pulsation you are seeing?
Sir, I'm not sure of this.
So when both outer and inner cortex of the frontal bone is lies, you are able to see the pulsation of even the dura matrix.
Yes.
Not that direct vessels you are seeing. Though it is a vascular endothelial growth factor, it produces a augmentation. Most often the pulsation you are going to see is the pulsation from the dura, the brain pulsation. So once you see a pulsatile swelling, you need to be extremely cautious that you are not seeing just a vessel.
Yes.
Can any thyroid produce an osteoclastic lesion? Thyroid carcinoma?
Sir, papillary thyroid.
No, normally it will not produce the bone. No, it will not.
It will go.
So you can get in a medullary thyroid carcinoma.
Yes.
Can produce an osteoclastic lesion. Okay.
So what is your clinical ground on which you gave this diagnosis? Suppose I say that patient has got a calcified nodule like that. Suppose I say.
Sir, one is that the history of the patient, at the age of the patient, she is an elderly patient who is 60 years old. And secondly, there is a recent increase in size of the swelling with the history of significant weight loss. And on examination, it is having hard consistency, and it was having it is hard in consistencies. So although there are no pressure symptoms or nodes here, because of these features,
I know that hard consistency you mentioned, and no doubt 25 years duration and 1 month duration, so rapid growth. Did you mention that same question I will ask, the fixity of the swelling to the prevertebral fascia or that swelling to the trachea segment?
It was moving with deglutition, but horizontal mobility was a bit limited, so it was not very much mobile.
It's been already clarified, no? Horizontal more than that. That particular nodule. See, in your case, you have mentioned a thyroid swelling with one particular nodule, correct?
Yes, sir.
See, you have mentioned the lobe enlargement with that. So specifically, you have to mention that. Okay, I know.
Yes.
You have to go back because time is catching up. So just make sure yourself have substantial points. Yeah, that's what I meant. Particularly, you mentioned that is hard and all that thing. So that one, the one which probably hard consistency, which you mentioned, that whether that was the mobility, that was the stuck to that prevertebral fascia behind, etc. You know, unlikely because patient it was moving with the deglutition. All right.
What do you mean by that deep to deep cervical fascia?
Sir, it means on extension of the neck, the prominence of the swelling.
No, you said prevertebral fascia is behind the swelling.
Yes.
So then how can you say it is deep to prevertebral fascia is also a deep fascia, no?
Sir, this is deep to the investing layer of the deep cervical fascia.
No, it is within the pretracheal fascia. It is enclosed within the pretracheal fascia. Don't use the word superficial because investing layer is quite superficial. Investing layer is, I mean, the prevertebral layer is posterior. So in between, you are having a pretracheal fascia which is enclosed in this.
Yes.
So your ideal term will be it is within the pretracheal fascia. How do you know it is within the pretracheal fascia?
It will move up with deglutition.
Very good. It is just because it's moving up with deglutition, you can say that it is within pretracheal. So the ideal word should be not using the deep to deep cervical fascia because cervical fascia has 3 layers. So here it is better to say it is within the pretracheal fascia.
Yes. Sir, can I continue?
Yeah, proceed.
I would like to proceed with investigations. I would like to do the quadruple or the triple investigations that we do. That is, first investigation, I would like to get an ultrasound of the neck, then thyroid profile and FNA of the swelling. This
you
is
use the word quadruple or a triple assessment in thyroid.
In thyroid, we usually tell it as a quadruple assessment.
But you started as a triple assessment.
The triple assessment is usually for breast malignancies.
Okay, so what does it include? Quadruple assessment.
Sir, it is history and clinical examination of the patient, ultrasound of the neck, along with the FNA of the swelling, and final aspiration of the swelling, and the biochemical profile, that is the thyroid profile.
Okay, good. Okay.
So the ultrasound of the neck showed that there was a inferior pole showed a large irregular hypoechoic solid mass of 3.2 into 2.5 centimeter, heterogeneous hypoechoic ecotexture, increased internal vascularity, joint dense calcification noted in the superior posterior part of the lesion. The left lobe appeared to be normal. There are few 4 to 6 right cervical lymphadenopathy seen in the jugulodigastric nodes, that is level 2, and posterior triangle showed fatty central column. Large impression was a large right thyroid lobe solid mass, likely neoplastic. These were the images of the same. Coming to the thyroid profile, the patient
is
had
there any significant on the node
status.
You have mentioned some characteristic feature on the node. Is it significant?
Yes, sir. The hypoechoic lesions usually tend to be more.
Node, cervical node.
Sir, cervical nodes on clinical examination were not palpable, but here 4 to 6 cervical lymph nodes there.
No, when you are saying there is a loss showing fatty central hilum.
Yes, sir. There can also be a necrosis at the central part of the node, which can be secondary to malignancy.
So when the fatty central hilum is present, it is in favor of malignancy.
No, sir. Usually the necrosis part, if there is central necrosis, that is going to be telling that there might be a malignancy. Usually fatty hilum tends to be normal.
Okay. So even ultrasound can pick up whether this node is a possibility of malignancy is more. There are features to see,
Yes, yes. Thyroid profile showed a euthyroid status. This was the fine needle aspiration report, which said tumor cells arranged in loose clusters, papillary fronts, and single cells were arranged with single cells are having a large were large and having a high nucleocytoplasmic ratio with pleomorphic nucleus. There were prominent nucleoli and scant to moderate amount of cytoplasmic nuclear overlapping was noted, and intranuclear cytoplasmic inclusions. Areas of calcifications were noted. The features were suggestive positive for malignancy, papillary carcinoma, to be correlated with biopsy. This was the lateral neck X-ray, which showed plain. This is a plain radiograph. That is lateral neck X-ray, which showed calcification in the upper part of the gland, and the trachea appeared to be normal, and the spine appeared to be normal. There's chest X-ray, which showed deviation of the trachea towards the left side.
No significant lesions in the lung. I just wanted to, on ultrasound, which is important, what are the usual sites of spread from thyroid to lymph node, which?
So firstly, it usually spreads to the prelaryngeal and pretracheal group of lymph nodes, that is level 6 group of lymph nodes.
Which is the exception to that? Where is it that it can bypass?
It can bypass to level 3 and level 4 group of lymph nodes, and that is the
when the primary is in the superior pole, typically.
Pole, yes.
Okay.
Yes.
So 3 and 4 is the next, and then
yes.
2 and 5, and what is level 7?
Level 7 is the mediastinal groups.
Okay, so that usually more extensive papillary or medullary only will have. Okay. And the ultrasonic features, sorry, I think you said, but what are the features of significant nodal involvement and ultrasound?
Nodal in the sense of lymph node status.
Yeah. What are the findings?
Sir,
the size, cortical thickness, echogenicity, additional features.
Sir, size of more than 1.5 centimeter, 1 to 1.5 centimeters, with usual central necrosis. I'm not sure about the
anything 9 millimeters or more is considered significant. Yeah. Loss of fatty hilum, cystic change, and you may have calcification similar to the primary lesion. So morphology of the node usually mimics the primary also. That's another characteristic here you have. That. Okay.
From reniform to oval shape.
Yes.
Can move on to the CT. What are the findings?
This was the contrast. It showed enlarged right lobe with the calcified nodule at the upper pole of the right lobe of thyroid, which needs further correlation, histology, and assessment for thyroid neoplasm. There are few abnormal enlarged inflammatory bilateral level 2 region and bilateral posterior lymph nodes. Okay.
So we have limited time.
The,
what is the indications for CT scan?
Sir, one is that if the thyroid is having a retrosternal extension, or if the patient, if the thyroid is, if the swelling is having retrosternal extension. Secondly, if there is loco-regional symptoms in the sense of pressure symptoms in which malignancy is suspected, then we tend to go for a CT scan. And if the ultrasound is showing the node positivity, then also when we are suspecting metastasis.
So you want to see the extent of the tumor when you have a large invasive tumor. That's one, as you said. Extent of nodal involvement. and
And
retrosternal extension.
retrosternal
Okay.
extension.
Additionally, it can also pick up metastatic lesions in the lung and the bone.
Yes.
Right. What is the most common pathology in thyroid cancer?
Most common
This
pathology
is
is
likely to
papillary
be
thyroid.
okay.
Yes, papillary thyroid carcinoma.
You can see here there's calcification. No? So what does that
In the
represent?
yes, sir. Usually calcification is more common in papillary carcinoma of thyroid. Dystrophic calcification that we tend to see.
Yeah, so these are large chunky calcifications in a patient who has had a goiter for 20 years, you said, no?
Very
Or
long.
25 years. So this the calcifications are likely to be from the original benign lesion. But here we have
Yes.
something called described as a broken ring sign, where if you see the ring pattern which is broken and there's a fleshy mass coming out, then it may have been that is represents the benign to malignant transformation.
Yes.
The usual calcifications in papillary are very fine stippled.
Fine micro calcification.
Micro calcification. And in pathology, they call it, when you see calcification in pathology in papillary, it's a finding
Yes.
Samoma body.
Samoma bodies.
Yeah.
Yes. Yes.
So what is the most common? Papillary is most common. Second most common cancer
Follicular neoplasm.
is actually variants of classic papillary, right? Under
Yes.
papillary, you have classic
Follicular
and
variant.
variant.
Follicular.
Yeah, follicular variants. Yeah.
Yes.
Second will be follicular
Follicular.
and medullary. Now about this. Follicular is much rarer now than you used to think, because many of the time it was follicular variant papillary and not actual. How does follicular carcinoma thyroid usually present?
Sir, usually it presents in 50 to 60 years of age with swelling in front of the neck, and this, if it is a metastasis, then usually it is the hematogenous route that which through which it metastasizes, usually to the lung, and again lung and bone with pulsatile
Classically to bone, yeah, usually
yes.
presents with bone metastasis, and the primary may not exhibit invasive features. You know, the follicular usually is capsulated and not classically invasive like what you're saying. Okay. Medullary, any characteristic?
So medullary usually presents in, it depends whether it is a sporadic or familial carcinoma. Sporadic usually tend to present in the later stages, that is after 50 years, whereas familial usually tend to present earlier, which are usually associated with men's syndrome. Especially if it is MEN 2A, it is usually 30 to 40 years, and it is less than 30, sometimes even in 20 years if it is a MEN 2B. And the usual metastasis that we tend to see most commonly, it is towards the lymph nodes.
Extensive nodal involvement. Okay.
Yes.
Thank you.
What will be the consistency in the medullary carcinoma?
Sir, consistency will be firm to hard.
Get hard.
Yes.
Variably, it is not very hard. No, it is a medulla. Right? There's a term wherever you are using the medullary carcinoma, it is depicting the medullary. What is Hurthle cell carcinoma?
Sir, Hurthle cell carcinoma is a variant of follicular neoplasm itself, where there are more
so
of
the new classification, Hurthle cell is not considered as a variant. It is a separate entity.
Yes. Usually we tend to see more of oxyphil cells or Ashkenazi cells, which are usually staining more with eosin because of the large numbers of mitochondria that we usually tend to see.
Will it produce nodal involvement?
Hurthle cell is also known to show nodal.
So it shows the features like follicular, but it gives the features of papillary like a nodal involvement. Separately, how do you diagnose it?
So diagnosis is based on FNA itself, sir. FNA is going to give you the Ashkenazi cells or the increased eosinophilic staining because of the increased mitochondria in the cells with increased cytoplasmic ratio.
So what do you want to do for this patient?
Sir, for this patient, I would like to go for the total thyroidectomy with right-sided modified radical neck dissection.
So what do you want to do for this patient?
Sir, for this patient, I would like to go for the total thyroidectomy with right-sided modified radical neck dissection.
So what do you want to do for this patient?
Sir, for this patient, I would like to go for the total thyroidectomy with right-sided modified radical neck dissection.
Is it what modification you are going to do the neck dissection?
Sir, usually we are going type 3 MR and right side MR&D, sir, in which we are going to save all the spinal accessory, internal jugular, and the sternocleidomastoid.
Are you going to do the type 3 or you are going to do the functional neck node dissection? What is the difference?
Sir, specific, if we are going to go for lymph node dissection of selective lymph node dissection of particular regions, then that is going to be called as selective when we are not involving the other structures.
No, what you are normally, when you do a thyroid, what you are normally expected to do? Are you going for a modified radical of type 3 or you are going to do a functional neck node dissection? What we normally say for a thyroid?
So we usually do, if it is medullary, then we go for central with ipsilateral lateral.
Your patient only, huh?
Sir, in our patient, we do a lateral neck dissections. Level 2.
Will you remove the level 1 node?
No, sir. Level 1 will not.
So that is the difference which we are talking about. When we talk about modified radical neck dissection type 3, there is a level 1 to 5 nodes.
1 to 5. Yes.
But here, there is in a thyroid surgery, when you are doing, you are not going to remove the level 1.
Yes.
So the ideal terminology is the functional neck node dissection, where though you are going to preserve all the 3 structures, whereas you are not going to remove routinely, the level 1 is not going to be removed.
Yes.
So what treatment further follow-up depends upon what?
Sir, further follow-up depends upon, we are going to monitor the patient. We are going to give the suppressive dosage of thyroxine initially.
All patient immediately.
Sir, we give it for 4 weeks until we go for we don't give it for 4 to 6 weeks because we want to look for a radio.
You want to classify the patient, it's a high risk and low risk, or you will just routinely do all the patient the same treatment?
Sir, for low risk patients and very low risk patients, we usually go for suppressive doses directly and follow up with thyroglobulin levels. But if it is a high risk patient, then we usually go wait for 4 to 6 weeks, in which then we repeat a radioiodine uptake scan. And if there are positive, then we might need to go for radioiodine ablation as well.
Suppose your thyroglobulin level is increasing, uptake scan is negative.
Sir, then we might need to go for a PET scan because if the radioiodine scan is negative and the thyroglobulin level is increasing, then there is some chances that the tissue is there which is not differentiated enough to take up iodine. We might find it out on PET scans.
What is that mechanism?
One of the indications for
why it is not taking up?
Sir, because the cells have lost the capability to take iodine and produce
due to the loss of
thyroglobulin.
The symporter.
Differentiation.
Symporter is not functioning, but FDG will be taking up. So you need to give a PET scan to do.
PET scan. Yes.
Good. Yes. Kanavel sir, you can take.
I think Paul sir also wanted to leave, sir. Maybe he can give his comments, then we will ask the candidate to do. Professor Paul sir. He's not with us. Dr. Shoaib, would you like to ask any doubts or any comments you would like to give?
I would like to thank all the eminent faculty to give me time, to give me an opportunity to present in front of everyone and taking out their time. Thank you.
Thank you very much. And can we, Madam Jyoti ma'am, are you with us?
Yes, sir. I'm there, sir. I'm there, sir. Hello.
Yes, madam.
Hello.
Madam?
Yes, I'm there, sir. I'm listening. I'm listening.
Okay.
Yeah, I'm there, sir. Sure. Do you have any doubts? Huh?
No,
This patient had some lung mets.
I would like to know that madam has prepared a candidate well, and candidate is good. And madam, thank you very much. Nicely done. Yes, madam.
Thank you so much, sir. Thank you. Thank you so much, sir. Thank you.
Madam and Shoaib.
Shanai, sir.
Yes,
thank you very much.
Yes, madam. Okay.
Okay, sir. Thank you, sir. Thank you.
Dr. Shoaib, you can unshare your screen.
Yes,
now
thank you
we
very much.
move on to Dr. Ashish. Are you with us?
Yes, sir.
Okay. Ashish, please share your PPT.
Yes, sir. Sure.
Dhanashar has joined now? No.
No, sir. I will see. No, sir.
Okay, okay. You start your PPT.
Yes,
Shrikumar sir, good evening, sir.
Can
Good
you see
evening.
the PPT?
Good
I'm
evening, sir.
here.
Yes, sir. Yes, sir. Yes, sir. All yours, sir.
Yeah, thank you. I was silently listening that thyroid. Good evening, Jailal sir. Good evening, Shanai
Good
sir.
evening, good evening, sir.
Sir, can you see the PPT?
Yes, sir, please. We are not able to see the PPT, Ashish.
One thing. Sir.
Yes, make it full screen, ma.
Yeah, sir. Right. Yeah.
Good luck to you.
Yeah. Good evening, everyone. Good evening, faculty. My guide is Dr. Janesh Belagar, Professor and Department of General Surgery. I'm from Terna Hospital in Mumbai. Mr. Sharad Mane, 52-year-old gentleman, residing at Dharashiv, an occupation by farmer, came to our hospital with a complaint of dilated tortuous vein on anterior lateral and medial aspect of right lower limb since 10 years and heaviness in right lower limb since 2 years, dark pigmentation of skin over right ankle since 6 months. Patient was apparently asymptomatic 10 years back when he noticed dilated tortuous vein over anterior lateral and medial aspect of right leg, which gradually progressed up to right knee. This vein become more prominent on prolonged standing and decrease on lying down. He complained of heaviness and dull aching pain in right leg since 2 years, which is more toward later part of the day and worsen on prolonged standing. Heavy work was gradually relieved by taking rest. There is also complaint of dark pigmentation of skin over right ankle for like 6 months associated with itching. No issue of bursting pain and swelling in calf associated with fever, intermittent claudication, prolonged immobilization, night cramps, ulcer in leg, abdominal distension or abdominal swelling, or no similar complaining opposite overfitting. Past no history of any comorbidity, no past surgical history, no any similar complaint in past. Patient is mixed diet, drinking alcohol once a week, bowel bladder habit normal, sleep habitual. No history of similar complaint in female. 52-year-old male working as a farmer present with complaint of dilated tortuous vein over anterior lateral and medial aspect of right lower limb, extending up to the knee for the last 10 years, which associated with heaviness and dull aching pain more toward end of the day since last 2 years, and dark pigmentation around right ankle since 6 months, which associated with itching. Can I go ahead?
Sound by
What type of pain the patient is having?
What's that?
If the patient is having any type of pain, you have asked for
Yeah,
the
dull aching pain, sir.
So why do you get the pain?
What's that?
Why there is pain in varicose vein?
There is pain due to a chronic venous hypertension and dilatation of vessel wall.
Chronic venous hypertension means what?
The chronic venous hypertension means there is incompetence of valve, so the venous spaces is there.
No, what do you mean by which system you are talking about? With chronic venous hypertension is a deep system or a superficial system?
Sir, superficial system.
What is ambulatory venous hypertension?
Ambulatory venous hypertension.
No. Whenever you are talking about chronic venous insufficiency, we are meaning the deep system.
Okay, sorry.
So why in a superficial vein you are getting a pain, and you ask the history of bursting pain?
Yes, sir.
And what is the difference between claudication pain? Can you get a claudication pain in the venous system?
No, sir. In arterial system, the patient gets claudication.
Venous system will not be there claudication.
Yes, sir. There might be claudication.
Okay, you are not prepared on that topic, but no, claudication you can get both in a venous system also, because the normal, when you are at rest, there will not be any pain because the blood supply which can be taken by the vein, precanalized vein can take over. But when doing exercise, there is a more blood is coming, which cannot be taken over. So you get a pain. So which we need to differentiate from arterial claudication, because instantly it will be relieved in arterial claudication. Here it will not relieved immediately. You need to change your position or raise your leg to take that change to take place. And in leg, you must always read and what are the types of pain and why you are asking about the pain and all those things. Srigimar sir, it is your field. You must ask now.
Some sound is there. Sandhil madam, can you unmute it?
Dr. Sandhil Rajakumar.
Yes.
Please
okay.
mute.
Yeah. Okay, Ashish, before going to it, how do you spell the claudication word? Can you spell it? At that point, two places.
Dr. Sandhil Rajakumar.
என்ஃபோர்ஸ்மெண்ட் டைரக்டரேட்டுக்கு இது பின்னடைவு வந்துட்டானுங்க. இப்போ அவர் தீர்ப்பே சொல்லிட்டாரு, இது எங்களுக்கு எந்த வகையிலும் பின்னடைவு இல்லைன்றானுங்க.
Can I well, sir?
Can admin mute it?
அது தண்டலப்பா பேசுனேன்.
Can I well, sir? Please mute.
Okay, that's fine. Ashish, can you spell the word claudication before going to topic?
Yes, sir. Claudication means while
no, spelling. You wrong spelling to claudication in your PPT.
Okay, CLUDICS.
Pardon?
CLUDICUTION.
No. It is CLAUDICIT.
Property ஏதாவது purchase இருக்கா இப்போன்னு கேட்டாரு.
Then claudication.
Property இல்லையானா?
Okay. So, these are the chronic venous hypertension. Is an acute venous hypertension is there? We are discussing about chronic venous hypertension. So,
yes, sir.
Yes, in some case of DVT, there is acute DVT. There may be distal hypertension, so this can produce that blood syndrome can lead to acute venous hypertension. That's also a possibility. Yes. So, what are the cause of pain in a varicose vein?
Due to so then
when there is acute dilatation of vein, second is there is hypoxia due to chronic venous insufficiency, and there is chronic venous hypertension. These are all causes of pain. It's pain. What can you define the claudication in a venous varicose vein? How does it appear? How do the patient feel?
So when while prolonged standing or heavy work, patient can work over a day, then patient may get a pain in a leg.
What type of pain it is?
It is dull aching pain.
Side?
A leg.
Which part of the leg?
So most probably on
foot.
Posterior aspect.
Pardon?
Foot?
Posterior aspect.
I'm not clear. Which
I think
structure is
you need to adjust your phone, but this coming sound is not very clear.
Hello.
Yes.
Yes, sir. Now clear?
Yeah. Okay, where exactly the pain occurs? The patient stands for a long time.
Yes.
It's just below the knee joint. How the pain is relieved? What are the procedures which will relieve the pain?
So pain relief while leg elevation with and apply crab bandage.
Okay, then? Anything else will relieve the pain? Which will differentiate from arterial claudication? Pain is relieved when the patient starts walking or do some exercise. It's the reverse in the arterial insufficiency, where the pain is more if the patient, if he work or if you walk or do some exercise. And it is also relieved by lifting the limb above the level, heart level, cardiac level. Okay. Why this history of prolonged immobilization important?
So due to prolonged immobilization, patient get deepened thrombosis.
Thrombosis? Without thrombosis also, is it important?
No, sir. Without thrombosis, no, sir.
Without thrombosis, there's no importance. If patient is coming to you with no history of DVT, but standing for a long time like a policeman, is the history is.
Yes, sir. Then there is varicose.
Pardon?
Yes, if there is a policeman or prolonged standing.
Yeah, how it becomes important or significant?
It's due to a primary or incompetence of valve.
Is it a primary incompetent? What is my primary incompetence? If somebody gets a varicose vein due to long standing like a teacher, it's a primary varicose, primary incompetence, secondary incompetence.
So secondary incompetence.
How it's important? Okay, you said that there is no history of ulcer in the leg. What's the typical character of this ulcer?
The ulcer is in a superficial and sloping.
What is the difference between venous ulcer and varicose ulcer?
Varicose ulcer is most probably on a greatest area, and venous ulcer also venous ulcer is also.
What do you mean by venous ulcer? What do you mean by varicose ulcer? So where is the problem? When you say varicose ulcer, where is the problem? When you say venous ulcer, where is the problem?
In varicose ulcer, the patient get ulcer due to varicosity, and in venous ulcer there is obstruction of venous system, and
what's the site of ulcer?
In varicose ulcer, sir?
It's varicose both.
So medial side of like about the medial major.
Not clear. Can you describe a venous ulcer? Site, size, shape, floor, like.
So venous ulcer is irregular in shape with a sloping edge with
sloping edges?
Yes, sir.
Floor, base?
Base is with granulation tissue is present.
Base is with granulation tissue, or floor is with granulation tissue. What is base of ulcer?
Define base of an ulcer. That's what I was asking. What's the inspection finding? What's the palpatory finding? Floor and base. What you see and what you feel. Floor and base.
Sir, in spectral finding there is a.
No. Among floor and base, what is you are seeing and what are you feeling? Okay. What is importance of abdominal distension?
So in abdominal distance, there is any it's for the compress the iliac vein and it's for secondary to varicose.
Pardon?
So abdominal distension or any abdominal distension any abdominal swelling that can cause the iliac vein compression and can cause the secondary varicose.
Okay. What is the common structure compressing iliac veins?
During
any syndrome, you know?
Main.
Yes, good.
Zoom meeting residents
Turner syndrome.
ते सर्जिकल क्लिनिक्स म्हणून असतात हा आमचा रेसिडेंट खूपच अल्सरचा फ्लोअर बेस पण
Next slide. Okay. One more. What cardiac illness produces varicose vein?
In varicose vein, there is if patient may get due to secondary varicosity due to deep
which cardiac illness cause secondary varicose veins? Why left side is more common varicose? Why left side is more commonly affected by varicose veins? What are the reasons? There are 3-4 reasons which makes left side as the commonest, commoner than the right side. What are they? Okay. Jailal sir, anything else?
Yeah, what is your by history? What is your diagnosis, no? By history, what do you think? What system you are talking about?
Lower limb venous system. Sir.
Oh, can you trace the long saphenous vein origin to incision?
Yes, sir. Long saphenous veins starting from the medial malleolus to the medially and go upward to the medial part.
No, starting at the medial malleolus from where?
From which vein?
From dorsal arch.
Where?
From dorsum of the arch. Long saphenous vein start from the external iliac vein.
No, be careful when you are answering. Long saphenous vein, what is the relationship external iliac vein and long saphenous vein?
From where it starts and course, because course is important for treatment.
Long saphenous vein starts from the medial side to the medial malleolus and go upwards from
as a continuous of which vein? As a continuous of which vein?
It cannot start all of a sudden, no? There must be some vein is continuing with that.
Yes, sir.
Then what happened?
Anterior, posterior to middle malleolus?
The anterior to medial malleolus. Sir.
Do you know any vein starts posterior to medial malleolus? Which joins with the saphenous vein?
Posterior tibial.
Posterior tibial is a deep vein. We are not talking about deep vein, superficial vein.
Short saphenous vein.
Have you heard the term posterior arch vein?
Yes, the posterior, yeah, actually, yes, sir.
What is the importance of that? Okay. So you can go ahead for the clinical examination.
Yeah.
General examination, patient examining well-lit room with both in standing and supine position after taking verbal consent. Patient in cooperative and well-oriented to complex and patient is well-built and nourished. Pulse is 76 per minute, regular rhythm, and blood pressure 118/78 mmHg in in supine position. Sitting position, respiratory rate 60 per minute, febrile, no pallor, primary sinuses, icterus, clubbing, lymphadenopathy, and pedal edema is present. Local examination, both lower limb, it is normal, gait is normal. In examination of right lower limb, inspection, dilated angles and tortuous vein present over the medial, anterior, and lateral aspect of the leg involving breast appendicitis. Localized pigmentation noted around ankle, no skin change like ulcer and scar, no brittle nail, loss of hair, no foot deformity seen, no cough impulse seen over femoral junction. The clinical photo of the patient. Palpation, no local raise of temperature, no tenderness along course of vein in calf. Tortuous dilated vein seen on the medial aspect of the leg starting anterior and Trendelenburg test 1, whereas it filled very quickly by column of blood from above, and positive Trendelenburg test 2, gradual filling of vein below upward. Modified persistence, collapse and vein pattern, multiple tourniquet test, perforator incompetence in medial to knee, perforator of leg. Pagan says positive defect can be felt or gap in the pressure which incompetent perforated. Morris's cough impulse test, cough impulse felt a second of femoral junction. Sensation over right lower limb normal or arterial pulsation are present. Percussion part test positive, auscultation no bruitous, regional lymph node, no palpable regional node present at inguinal and popliteal region. Left lower limb, there is no evidence of varicose vein and deep vein thrombosis and incompetent perforator. Systemic examination, cardiovascular system, S1, S2, no murmur, respiratory system, bilateral air entry present, no added sound. Per abdomen, no dilated vein, soft, per abdomen soft, no palpable mass, bowel sound present. Central nervous system, no focal neurological decision. For rectal examination, normal sphincter tone, no palpable mass, normal fecal staining. Diagnosis of case of primary varicose vein affecting breast system of vein in right lower limb with incompetence at femoral junction with below knee and above ankle perforator incompetence with pigmentation without lacodermatous sclerosis. As per CEAP classification C4A, C4A means very clinically varicose skin changes with pigmentation. CEP means etiological, there is primary. ASP means anatomically superficial and perforated present. PA means pathologically reflex due to reflex.
Can you go to the first slide of examination?
What's that?
First slide.
Go to the first slide.
Yes, sir.
Okay. Which all tests will you do in the standing position and what test will you do in a supine position?
Sir, I will do a Trendelenburg test and Persis test and a multiple tourniquet test in standing position.
And lying position.
And
what are the tests you do when the make a patient lying down and then you do the test?
Yes, sir. Sir.
How will you do Morris's cough impulse?
Morris's cough impulse and Pagan's test are doing lying position.
Which one you did? Trendelenburg 1 or 2? Which one you did first?
First, I can do a Trendelenburg 1. Sir.
What is Trendelenburg 1?
In Trendelenburg 1 case, and first supine position, patient supine, and the limb was raised and empty the vein, and then tie a tourniquet at below the section of femoral junction and ask patient.
What you look for in the Trendelenburg 1?
Yes, sir. In Trendelenburg 1.
Filling from the above or filling from?
Filling from the above, sir.
Filling from above.
What's the inference? If it is filling.
What, sir?
If it's filling, what does it mean?
That means the saphenofemoral junction incompetent.
Competent. Okay. When the two is filling from above, below upwards.
Sir, Vandenberg 2 test is below upward and is suggestive of perforator incompetence.
Have you done the multiple tourniquet test?
Yes, sir.
Where all you have ligated the tourniquet?
Sir, I ligated a tourniquet just below the saphenofemoral junction. One is above the knee and one is below knee.
No, which one you ligate first?
First ligate the below knee, sir.
Below knee.
How much
Only
compression will
three.
you apply? Sorry.
Go ahead, sir. Go ahead.
How much compression will you apply for a tourniquet?
So for tourniquet, we apply 3 compressions, sir.
Pardon?
3, sir.
No. How much pressure will you apply?
So we can apply 30 to 40 mm.
Why 30 to 40?
What is your logic?
Which is to be occluded, which is not to be occluded. That's the logic.
Superficial vein to be occluded, and we have to occlude the superficial venous system.
Which is not to be occluded. What are structures not to be occluded?
Some structures, blood should come to the vein, no? So,
Deep venous system.
deep venous system. So your multiple tourniquet test is positive here. What was your inference of the multiple tourniquet test?
In multiple tourniquet test, there is a multiple perforator is incompetent. Multiple tourniquet test is positive.
Well, what tourniquet? Which segment perforators are incompetent?
Sir, in multiple tourniquet test, there is a leg perforator and below knee perforator is
what is leg? What is below knee?
Pocket and boards.
No, what do you mean by leg? From where to where is called leg?
Sir, below knee to ankle, till ankle.
Very good. So that is a, don't say again a below knee. So the ankle perforators, what is the perforators you have seen?
Also,
what is the named perforators in the ankle region?
In ankle region, there is a named cluster.
No, what is the purpose of that vein? Which connects what vein? What do you mean by perforator?
Perforator is superior venous system connect to the deep venous system.
So what is the superficial system here? What is the deep system is connecting? The vein connects to, this perforator connects two veins. And what are the veins?
Superficial long saphenous vein connect to that.
Okay, it is not long, but it's a posterior arch vein. And what is the deep system?
The posterior arch vein and anterolateral vein and posteromedial vein.
What is the deep system of veins? What are the other deep veins you know in the leg?
Tibial vein, popliteal vein, and femoral vein.
Anatomically, how it differs from the superficial vein? What's the difference between deep system and superficial system anatomically? Or structurally?
By what you say that is superficial, by what you say it is deep? So your multiple tourniquet test is positive, and you said you have also done the modified persist test.
Yes.
What you are going to look for in the modified persist test?
In modified persist test, we look for deep vein thrombosis.
No, what you are going to see?
So in modified persist test, we can see if there is a more prominent, if during test there is collapsing of vein system, then it collapse the vein, then it deep vein is patent.
Collapsing of vein?
Strengthen.
Already your perforators are incompetent.
Yes, sir. If vein is shrunk, then is
no, you are said in your case, you have put a finding, there is a collapsing of the vein. Next slide you go. Next.
You said about gait. What's the importance of gait in varicose vein? Second slide.
Sir, in if patient have chronic varicose ulcer, then patient may get equinus gas.
Pardon? Equinus. What's the importance of it? Identify the gait, equinus deformity.
What is that? Equinus deformity means what? How will you say this patient is having equinus deformity? Looking at what?
So looking for a patient champagne bottle.
And what you are using a fork heel he is using, or he is working with the toes? Any significant on that?
His patient is walking on a toe. Due to that, the patient Achilles tendon of Achilles is shortened. The patient have equinus deformity. Patient is walking on a toe.
Okay.
So your modified figure, persist test result.
What's on?
Next slide. Modified persist test.
Yes.
Is collapse. What is collapse you are seeing here?
Sorry, not collapse. Strengthen the vein, and if deep vein DVT is present, there.
No, in your case, what was the finding?
So in my case, there is deep vein system is patent. Sir.
That is okay. So what you seen? What has happened to the vein? Superficial system of vein. What has happened?
The superficial vein is strengthened. Sir.
I'm saying a deep vein. Please, sir, please.
No, whenever you are having a multiple tourniquet test positive, your perforators are incompetent. So automatically your perforators will get engorged, even when the deep vein is normal. So how you are going to differentiate in the modified persist test? You are seeing it is a collapse. You will not get a collapse of vein when you have a perforators is incompetent. That means you are not done the test. That obviously will tell us that you are not done the test properly.
They get it? Even with the patent deep vein, if the perforator is incompetent, the vein cannot collapse. Okay. And on the other side, if this patient has a deep vein thrombosis, what will be the finding in modified persist?
So if deep vein thrombosis, then dilated vein, superficial vein is more dilated, and
any symptoms?
And the patient have crampy pain. When patient is
patient will have a crampy pain and the veins become more prominent. It cannot collapse if the perforators are incompetent. If the perforator is competent only, sometimes that may collapse. Even then, it's a difficult finding. Okay.
So you said there is a pigmentation, no?
Yes, sir.
Where is the pigmentation? Where was it?
Around the ankle.
Show us the picture.
Yes. Yes.
Where is the pigmentation?
Around ankle, sir.
Why there is pigmentation? Why
pigmentation.
this patient developed pigmentation?
Due to
Pathogenesis for pigmentation.
due to chronic due to fibrin cup therapy theory. Fibrin cup theory.
Fibrin cup theory for pigmentation. So you need to prepare very well. Huh? Which theory is accepted, what is not well accepted, what is ambulatory venous hypertension, and why you are getting. So all that is very important because these are basic. These are the basic question which will be asked.
Anatomy of the vein, because knowing anatomy is the base of treatment. Unless you know the anatomy perfectly, you cannot treat the patient.
Yes.
Recurrence is mostly due to the lack of knowledge of anatomy by the surgeon. Incomplete treatment.
How you are going to proceed?
Yes.
So in this patient, I would like to do first.
How will you evaluate this patient?
We evaluate with venous Doppler scan with B mode to look for functioning and anatomical structure of the venous system.
You are doing a Doppler, you are asked the radiologist to do Doppler. What are these? What are the specific points will you ask for in the Doppler? What are the specific points will you ask the radiologist to give you when doing Doppler? Or you are doing Doppler, what are the specific points you look for? Have you seen a Doppler report?
Yes, sir.
Okay. In the Doppler report, what are the points we look for?
To look for a saphenofemoral junction competent or incompetent. Or,
yes. When will you call it incompetent? What are the radiologic feature of an incompetent saphenofemoral junction? Okay, next point. No. You are just Doppler. Doppler, what are things will you look for? One is saphenofemoral junction. Then.
And any deep vein thrombosis there on.
Okay, sonologically, how will you say deep vein is patent or thrombosed?
Any phases, any augmentation,
compression,
phasic flow?
Yes, sir.
What do you mean by Doppler?
Shikmar sir,
yes.
Maybe we should allow him one more chance after some time, sir. If he is finding difficult to
That's
take
a good option. He's totally underprepared.
Sorry, sir.
He's totally underprepared. So
yes, sir.
He prepared the same topic and come back after some time.
Yes, sir, I request you, Dr. Shanai sir, Jailal sir, to quickly sum up the management part of his case so that it becomes a message to the students. I will allow Ashish maybe after 2 or 3 weeks time, he can come back with a fresh case and start presenting with us. He just moved to the second year, probably that is one challenge. And we also gave him very limited time, sir.
Okay. We're not blaming him, but for such a discussion, you need some more. Only
sure.
If you give feedback, only we can take forward discussion also.
Sure, sure. Yeah. Maybe we can sum up and allow him to time, sir. What is your take on it, sir?
That is better. Srimas sir can give a short discussion on the management and then we can end.
Then we will call a close, sir.
So Ashish, what you need is a Doppler evaluation. Doppler, we have to look for the saphenofemoral junction competent. how a reflux is there. Reflux is lasting more than 500 milliseconds is a significant reflux. The grades of venous vein dilated or not, the size, normal size is less than 1.6 millimeter. Then you look at the deep vein, there's the phasic variation, there's augmentation, there is compression present. Normally, if they're absent, you have to suspect about deep vein thrombosis. Then you have to look at the perforators where the any reflux is there. Size more than 3.5 millimeter or more than 300 milliseconds reflux is there. That is said to be a significant perforator. So these things to be reported and recorded, which all perforators are incompetent or not. Depending on the findings, we decide what type of treatment. Before proceeding to it, you have to do the investigations to assess general condition of the patient, like a routine blood examination, look for diabetes, and all those things. One thing I missed is always look at the pulses. So if there is a peripheral vascular disease, if the patient does this varicose vein is not so severe, better not to treat. Sometimes we have to do need a saphenous vein, do a graft later from bypass or that. So make sure that there is pulse are present, and make sure there is artery insufficiency. And one point against doing again varicose vein in a case of pure peripheral vascular disease is one important part of varicose treatment is compression. And in a case of POVD, if you compress it, it will exacerbate the arterial disease. So because of these two reasons, always look at the peripheral pulses before you proceed. Then you do look for the diabetes, all those things, general evaluation, anesthesia evaluation on those things. Then by the Doppler report, you can decide what type of treatment you can do these patients. So basically surgical, the three types of treatment. One is conservative treatment, which is ideal for very early lesions where the patient can be advised to have good exercise, weight reduction, proper walking. Then compression stockings, grade 2 compression stockings, which will apply a pressure about 30 to 40 milliliters of mercury. Then if the patient is symptomatic, then you have to think about either surgical or endovascular treatment, endovenous treatment options. Surgical is classically a tunnel lumbar operation plus perforate ligation with or without stripping of saphenous vein. So it's a tunnel lumbar operation has three components. One is flush ligation of the saphenofemoral junction. That is, you have to go as close to femoral vein as possible, but never injure the femoral vein. So you dissect out the saphenous vein, divide, ligate and divide all the tributaries. There will be 3 or 4 named tributaries, but there will be 6 or 7, even up to 10, 11 tributaries are there. All these tributaries has to be identified, ligated and divided. Otherwise, these tributaries may act as a possibility of recurrence in future. So all the tributaries has to be ligated, but some surgeon says you can leave the closest tributary to saphenofemoral junction, such a controversy. But at your point of level, you have to ligate, theoretically, you have to ligate all the tributaries. Then go as close to the femoral vein in the fossa ovalis without affecting the femoral vein. You have to ligate. Then that's a second part. Then third part is you have to resect at least 2 inches of the saphenous vein to prevent recanalization or recurrence. So classical tunnel lumbar has 3 components. One is flush ligation, ligation of all named and unnamed tributaries, and removal of at least 2 inches of the saphenous vein. Then you go to the perforators, which all perforators you mark as incompetent, has to be identified and ligated, the second option. Then removal of saphenous vein is usually, I don't do it, but some surgeons do this stripping of saphenous vein. Third mode of treatment is endovenous options. You have 3-4 options. Classical one is endovenous laser, radiofrequency ablation, some medicines like foam sclerotherapy, or some people comes out with a hot water treatment also. The principle of endovenous and radiofrequency ablation is you apply some energy which will damage the endothelium of the vein so that the vein gets collapsed. So in endovenous laser therapy, you use laser waves which of various lengths, 980 nanometers to 1470 nanometer lasers. You apply, that is by the phonological control, you introduce the laser fiber in the saphenous vein above the knee joint. Below the knee joint, better not to apply it because the chance of injury to saphenous nerve and sural nerve is there. So better not to do it below to it. So what you do is introduce the laser fiber just above the knee joint, and the distal tip is adjusted 1 inch below the inch distal to saphenous from junction. You apply laser and burn it completely. Radio frequency ablation, you apply radioactive forms. Radio frequency waves, which will produce heat energy up to 120 degrees centigrade and burn this. Third thing is you can give form sclerotherapy, but basically the form is made of poldacanol and air or carbon dioxide mixture. You inject it smaller veins, bigger veins, the result is very poor. The fourth one is now this glue is available. The glue is injected into these veins and gets included. So these are the different methods of intravenous treatment. Advantage of intravenous treatment is there's no scar. The patient can be back to activity immediately. Chance of recurrence is also less compared to surgery in certain studies, but of course there are controversies regarding the same. So this is the treatment in a nutshell. And the complications of it's basically the complications are basically most important complications deep vein thrombosis in the post-operative period. So these patients need early ambulation, sometimes heparin and other supportive measures. They need compression stockings, except when you're using glue, where compression stockings is not routinely required. Other patients do need a compression stockings. So this is in short about the management. Sir, any other points I missed?
No, that is very, very effectively you have narrated this. Can I, Rajay, I mean, Tanai sir is here and he must.
Yeah, nothing, just since most of we have heard from horse's mouth, just for Ashish and all the postgraduates. Hello?
Yes, sir, we are with you.
Yeah, nothing, just to say that varicose veins, one of the common cases for you people, number one. And there is also, this is people say, comparatively a difficult case presentation. So whatever it is, number two. Number three, the basic problem you should identify, Dr. Ashish, is firstly, yes, anatomy is a must, because first you have to find out medial veins or lateral veins. Accordingly, the questions will start. So is it long saphenous territory or short saphenous? First. Next question that comes is the saphenofemoral is incompetence or not? Or is the saphenopopliteal is incompetence or not? Okay. So medial or lateral, saphenopopliteal or saphenofemoral. The next question that comes is the patient having deep vein thrombosis or not? So further adding on to this, is it unilateral or bilateral? The next question that comes is abdominal examination, in the sense, whatever you have to rule out other causes in the abdomen. So this is how the questions will go on, asking you. So each question, each test, whatever, which have been asked to you, you have to just don't try to say deep vein thrombosis negative. See, you need to tell the findings. Always, you need to tell the findings. Accordingly, you do the interpretation. And the best way to learn all these things is get involved with the patient management, including clinical examination, and then go to the radiology department. Today, the test may not have the great relevance, especially varicose veins, but not that it should not be neglected. So as rightly pointed out, arterial examination pulses very, very important, because people with the varicose vein, just like that, they come and patient is actually having claudication of arterial origin and veins are prominent. So you do a Trendelenburg's and get into trouble. So because of the compression. So please go to the radiology department before you complete your whatever 3 years course, that you need to look at both arterial as well as venous Doppler, how they do, augmentation, compressibility, coughing, everything. So this is the only way to learn. Whatever we teach you, whatever. So unless you go, get involved with the practical management of the patient. That is the best way to learn. I think connect well. That's a very small advice for this. Thank you.
Yeah, good.
Can I speak something?
Yes, sir, please.
Ashish.
Dr. Ajay Khanna here. Dr. Ajay Khanna here.
Please, sir.
I think Dr. Shiv Kumar has given the brief description about the varicose veins, just for remembrance that what are the various minimal access techniques which are available for the varicose vein, because that is always a question nowadays will be coming in the examination, that what are the various minimal access techniques for the varicose veins. Now, basically, you can divide these two techniques into the thermal treatment and the non-thermal treatment. The thermal treatment is the type of the treatment where the energy is used, like you can use a laser, you can use a radio frequency ablation, you can use a microwave, or you can use the steam. So these are the 4 types of the thermal treatments which are available. And then in the non-thermal variety, there are 3 types of the things which are there. One is called the MOCA. MOCA is mechanico-chemical ablation. Second is the glue treatment. And third is the sclerotherapy. And now the sclerotherapy has come in a big way for the treatment of varicose veins, not even for the reticular veins or the telangiectasia. Even for the truncal veins also, you can use based on the ultrasound, you can do the guidance of that, and you can treat a good number of the veins by that way also. And now the third treatment which is there is what is the non-invasive treatment which is available, and non-invasive treatment is in the form of the ultrasound, what is called the HIFU treatment, high frequency ultrasound. And there you do not give any injection or anything, only with the help of the high frequency ultrasound, you can treat the varicose veins. So these are the few things which I think the student may remember, especially for writing in the examination part, because many times a short note on this always comes in the different type of exam, whether it's the MS examination or the DNB examination. Just wanted to say that, yeah. Thank you.
Respected faculty, can we call the session a close for the day?
Yes.
Okay. Ashish, good night. You take this as a message for you to gear up, get back to the library, speak to the vascular surgery department, go to the radiology department, spend some time. All of us have gone through this. Don't feel bad about it. But then there is always avenue to spring back to the regular academics, right? So I will give you a month's time. You can bring back yet another case, either a vascular or any other case here, and we can definitely allow you to present once again. Okay? And good night to you.
Good night. Good night, sir.
All the